So after talking about what is encephalitis, how it can manifest in the patient, and what are different viruses which can cause encephalitis, let's talk in the second section now some antiviral therapy. The common antiviral therapy we will talk in this section will be the basic management and supportive therapy. Always remember, viral infections usually they need lot of supportive therapy and basic management as compared to the specific therapy. So basic management and supportive therapy is very important part of the antiviral therapy. Then we will talk about complications of antiviral therapy and also pseudofovir and intravenous ribavirin therapy. So treatment, specific antiviral therapy. Usually we should closely monitor the respiration and blood pressure of the patient with the encephalitis, and care in intensive care unit ICU is usually given to the patient with encephalitis. Basic management and supportive therapy is the careful monitoring of cranial pressure. That's very important. Fluid restriction, avoidance of hypotonic IV solutions, and suppression of fever. So these are some supportive measures. We said it presents with the febrile illness. Sometimes fever may be really high, that can cause seizures and other side effects. So suppression of fever is important. Fluid overload should be avoided, restriction of fluid, and then we should monitor the intracranial pressure very closely, and then avoid hypotonic intravenous solution. Standard anticonvulsant regimes can be given. We usually encephalitis patient, they have seizures, generalized or focal seizures are present, so we can treat them with anticonvulsant therapy. Prophylactic therapy is Acyclovir ingestion. So Acyclovir is very common antiviral therapy that can be used. So Acyclovir ingestion. Acyclovir is diluted before administration. Each dose infused slowly over 1 hour. So Acyclovir, which is diluted before giving, and it is given slowly over a period of 1 hour. Neonatal herpes simplex virus CNS infection. Less responsive to Acyclovir therapy than herpes simplex and encephalitis in adults. So Acyclovir is less effective in children as compared to adults. Next, another treatment, we have alkaline pH of Acyclovir. What does it do? It can cause local inflammation and it can cause phlebitis, inflammation of the veins. Phlebitis is inflammation of the veins. So it can cause local inflammation, cause phlebitis. Dose adjustment in patients with impairment of the glomerular rate, impaired GFR. So dose adjustment in patients should be given, should be done in patients who have impaired glomerular rate. Penetration into cerebrospinal fluid is excellent, and drug is 50% of serum level in cerebrospinal fluid. Complications of the therapy, we have elevation in blood urea, nitrogen and creatinine. That's why dose adjustment is required in patients who have defective glomerulofiltration rate and decreased glomerulofiltration rate, because it causes elevation in blood urea, nitrogen and creatinine. Thrombocytopenia, gastrointestinal toxicity, nausea, vomiting, neurotoxicity, lethargy or obtundation in 15%. So all these are the complications of the antiviral therapy. Next is Acyclovir resistance. Sometimes develop patients do not respond to Acyclovir. What are the causes of that Acyclovir resistance? It is mediated by changes in the viral deoxypyrimidine kinase. It can cause changes in DNA polymerase. So these are two factors that cause the resistance to Acyclovir: change in the virus itself, virus deoxypyrimidine kinase, changes in DNA polymerase. Virulent Acyclovir resistance, herpes simplex virus isolate from sites outside central nervous system. In immunocompromised patient, and including those with AIDS. So AIDS patients are immunocompromised. They have virulent herpes simplex virus isolate in patients from sites outside central nervous system, immunocompromised patients, patients with AIDS. Treatment, again, some other treatment options. We have adjunctive intravenous glucocorticoids can be used. Role is unclear. CMV-related CNS infection, cytomegalovirus, CNS infection, they are treated with the Acyclovir and foscarnet, and also cidofovir. Induction therapy is followed by the maintenance therapy. So initial therapy followed by the maintenance therapy. Then we have induction therapy is until decline in cerebrospinal fluid pleocytosis, different cells present in the cerebrospinal fluid. Until they are decline, we should give the induction therapy. Reduction in cerebrospinal fluid, CMV DNA. Treatment is limited by, if these complications occur, we should stop the treatment, we should reduce the dose. Granulocytopenia, granulocytes are decreased, thrombocytes are decreased, or therapy reduction or discontinuation. Gastrointestinal side effects include in 20% of the patient, gastrointestinal side effects are present. Then the treatment of cytomegalovirus retinitis. Cytomegalovirus infections involves the retina of the eyes, causing retinitis. Acyclovir, and it can cause also CMV retinitis, leads to retinal detachment. Then we can also use foscarnet, which inhibits viral DNA polymerases. Complications are the tetany, cardiac rhythm disturbance or cardiac arrhythmias, seizures, fatigue and nausea, reduction in serum calcium, magnesium, and potassium level. Cidofovir treating cytomegalovirus retinitis, this is used. limited efficacy in human cytomegalovirus central nervous system involvement. Usual dose is 5 milligram per kilogram intravenously, once weekly for 2 weeks. If prehydrated, probenecid 3 hours before cidofovir is used. Nephrotoxicity is common with cidofovir, and renal function deterioration is also possible, and if that is present, dose reduction should be done. Next is intravenous ribavirin therapy is a benefit in isolated cases. Encephalitis due to California encephalitis, benefit for rare patient, benefit in infants or young with severe adenovirus or rotavirus encephalitis. Encephalitis due to LCMV or arena viruses. So these are some indications or conditions in which we can use intravenous ribavirin therapy, and it is usually in infants or young children with severe adenovirus or rotavirus infection or arena virus infection or LCMV. So all these are the indications in which we should use intravenous ribavirin therapy. Hemolysis occur with anemia is major side effect of this therapy. Next, the infection caused by Western Nile virus encephalitis. No specific antiviral therapy. Interferon ribavirin can be used. Humanized monoclonal antibodies, WNV chimeric vaccine is available human testing. Chimeric and killed inactive vaccine is also safe, and it's effective flavivirus vaccine. So these are also different vaccines which are also available for the treatment. Now the sequel of this is variation in incidence and severity of the sequel occur, how the patient later on will present or how they can, different complications can affect the person. With EE virus infection, they have 80% survivors have severe neurological sequel. Severe unusual sequel occur due to EBV infection, California encephalitis virus, and Venezuelan equine encephalitis virus. So with these viruses, severe sequel occur, and with Eastern equine encephalitis virus, it's 80% have severe neurological sequel. Again, incidence and severity is directly related to age, level of consciousness at therapy begins. So when the therapy is started, what was the level of consciousness? Those with severe neurological impairment could not survive and they die. Good neurological function at the beginning did better with therapy. So all these were the antiviral therapy treatment options, and then we have their complications and sequel that can occur along with encephalitis. Thank you for watching Scardia.com.